Well, it's a real pleasure to be here. It was a little tricky getting down here, so I'm especially happy to be here considering the weather yesterday because it was a 16-hour adventure. My name is Laban Lester. I get the pleasure of talking to you about managing the difficult airway and go over some of the updated guidelines, and it's really a nice overview, I think, of just thinking about airway management and difficult airway management. I'm the co-founder of MD Air Support. It's not related to this. And we did a study where we got supernova masks from Vyaire in the past. Goals and objectives today, we're going to talk about some of these key updates from 2022, previously from 2013, and how that kind of affects how we think about pre-airway management, awake airway management after induction of anesthesia, and review some of the infographics that give us some more information on how we think about these, and discuss some options for optimizing oxygen delivery. And we'll also talk a little bit about some alternative approaches to airway management, just to have that in mind. Let's think of a case just to ground us in thinking about airway management. So this is a 57-year-old male who was very obese. He had a jaw fracture. He had a BMI of almost 60, and he needs nasal intubation for ORIF and wiring. So 2013, the guidelines here, and 2022, we had some changes, although I must say the concepts are really similar, but we're really emphasizing how we think of them and how we integrate them into the system. So we still think about this as pre-assessment, the possibility of awake or asleep intubation, and how we manage it. But when we think about what's going to make someone difficult for intubation, are they going to cooperate? Are they going to be difficult for mask or supraglottic airway? Are they going to be difficult for laryngoscopy and intubation? Or are they going to be difficult for surgical access? And then continue also thinking about opportunities for delivering oxygen. But you can see in 2013, this was just sort of written into it. But I'm going to emphasize this component because I think it's an underrated one, and I'll emphasize it a few more times here. So looking for opportunities to deliver oxygen. And then we're still thinking about sort of awake intubation versus intubation after general anesthesia, non-invasive techniques or invasive techniques, video laryngoscopy or video-assisted approaches, and preservation of breathing versus not preserving breathing. And so, again, awake and asleep, or oral or nasal endotracheal tube versus surgical airway, video laryngoscopy, and then spontaneous breathing really versus paralysis is really kind of how we think of it. So in 2022, this is updated. So some of that pre-assessment component is integrated into the algorithm, which I think is quite nice. There's also this kind of emphasis on thinking about pre-intubation, awake or asleep, and then there's an emphasis on choice. So there's really a switch to emphasizing that the clinician managing the airway can say this is not being dictated by something from above. So people at the bedside are sort of a little more empowered to make decisions that are appropriate for the resources that they have. So again, similar concepts, we'll review them again because they're really critical to airway management. So is this a suspected difficult airway or not? So if it is, then thinking about are they difficult in what way? So mask and supraglottic airway, high risk of aspiration, high risk of rapid desaturation is an important component that's sometimes overlooked. And is it going to be difficult for an emergency invasive airway, say a surgical airway? So very similar ideas, but integrated now into the algorithm, which I think is quite nice. So if the answer to these questions is mostly no, or there's something that you can overcome with management, then proceeding to intubation after induction of general anesthesia is appropriate. But if any or all of these are yes, it's up to the clinicians to decide if you're going to intubate awake and switch your algorithm in that way. And any one of these is potentially enough to put you over. So if the patient's so high risk for aspiration, it is totally reasonable to do the intubation awake if you deem that to be the right approach. Okay? It doesn't have to be all of them. Again, now the optimization of oxygenation is right literally in the center of the algorithm. So optimize oxygenation throughout. I'm going to get back to this as a really important kind of component for review for everybody. Okay, intubation attempt with awake intubation. This is really similar between the two. Okay, so not a lot of difference there. You do an awake intubation, you're successful. If you fail, you got to think about other options. They laid it out slightly differently, consider postponing the case, et cetera, but it's really the same information presented very similar manner. Then getting into the intubation after anesthesia, again, one key component is limiting the number of attempts. You don't want to make it worse. You don't want to cause swelling, bleeding, things that make an already difficult situation much more difficult. And here, if you are able to ventilate, it's really different in how you approach it, but still thinking about limiting attempts, getting help, really important, critical kind of components. The other thing they've added is some infographics that kind of integrate these approaches a little bit more directly into the algorithm or have other ways of giving people information. So this is just another approach to the pre-component. And this tool can be used to choose between the awake or the post-induction airway strategy. And then this is that emphasis. Each assessment should be made by the clinician managing the airway. So moving the power to make a decision to the team at the bedside, which I actually think is an important component here. This is just thinking about the awake versus asleep, and they put it in a way that might be easier for some people to appreciate, but still has the same awake or asleep. The reminder for oxygen is critical. Consider postponing if you need to, and then thinking about alternative techniques. So this could be awake invasive technique, like or an alternative anesthetic, regional approach, or something like that. In unstable patients, it emphasizes that you may need to proceed and think about things as what I would call a double setup, where you're preparing for induction of anesthesia and intubation from above, but you are set up to do a surgical airway. This is really the cornerstone of rapid sequence intubation in trauma, and why it's so often successful is you have a built-in backup plan with the surgical airway. And then management after induction of anesthesia, this is really critical. And this is actually kind of gets at a way of thinking about this in which we consider methods for optimizing oxygenation and ventilation. So if you're having trouble and you're able to mask ventilate or a supraglottic airway is in place successfully, you're really kind of in the green zone. You want to maybe get help, think about alternative plans. If you're in a situation where you're not oxygenating and ventilating, so you don't have gas exchange, you don't really have an airway, then the idea here is to optimize what you're doing. So optimize your face mask or supraglottic airway or your intubation from above. And the key component of this is once you get to that can't intubate, can't oxygenate situation, you need to move forward to a surgical airway in a time-dependent fashion. So that doesn't mean immediately, but you have to be thinking about it, and you have to do it really before the patient essentially arrests. This is the key element. And what are some approaches there? So really the standard, and we'll go into this a little more, is the cricothyroidotomy, but there are situations in which something like rigid bronchoscopy or even ECMO, especially might be important. Once you are truly in a code situation, you're often late for ECMO. It does take time. Okay, so this is the same thing, just a little more larger. And part of the addition of this relates to this, what's called the vortex approach. That was a way of looking at kind of airway. And you can see here this funnel-shaped approach on the left of the screen. And when you're green, you're in good shape. You're oxygenating, you're ventilating. When you are not, you can use optimization of mask ventilation, supraglottic airway, endotracheal tube, and here it's more of a picture. And then as you go down this funnel, if you really get into that can't intubate, can't oxygenate situation, you need to move towards the surgical airway. And so I think the ASA difficult airway algorithm has recognized that kind of visualizing this in this way can be somewhat helpful, and I think that's what that approach came from. Okay, techniques for oxygenation. This is really important, optimizing oxygenation throughout the management of the difficult airway. So high flow nasal cannula can be incredibly valuable in this situation. We'll show a picture again here. Just of note, the The Fisher-Paykel Optiflow was just approved for anesthesia. It actually, even though it's used sometimes in anesthesia or procedural suites, it wasn't actually approved for sedation anesthesia. It is now approved for it. And it's approved with a device that has a filter, so you can use it, the circuit for 24 hours and just change that nose piece. So a nasal anesthesia mask, we're using CPAP or BiPAP approaches. Using a nasal cannula cranked up during intubation can be helpful. And then blow-by or face shield. And so this on the left is an example of the high-flow nasal cannula, which you're all familiar with. But again, it is now approved for use for sedation in procedural suites and operating room. It wasn't previously. That newer device, just of note, doesn't have the blender. It's a little simpler approach. Looks very similar, but no blender, so you can't change your FiO2 on it. And those devices do enable a bit of CPAP. This is in the middle is a nasal anesthesia mask, so this enables use with an anesthesia circuit or with a Mapleson circuit to provide positive pressure, and then you can also augment the amount of flow up to about 30 plus liters per minute. And then just cranking the nasal cannula, there is some data that is helpful. Positioning is super helpful in difficult airway management and definitely is a way to prevent getting into some of these difficult airway situations. So reverse T-Berg is probably one of the better positions. Sitting up is better than laying completely supine. So some alternative techniques using video-assisted laryngoscopy or using combined techniques where you say use your video laryngoscopy with flexible bronchoscopy. Bronchoscopy is still a major cornerstone and still a critical skill to maintain. And then now with the rise of second generation intubating supraglottic airways, that's definitely a very useful approach as well. There are some alternative blades. Lighted stylets and light ones were supposed to come back on the market. I haven't actually seen them. Various introducers, there's some rigid stylets and intubating stylets that are available, or tube changers using what you have. And then just really good extralaryngeal manipulation can be very helpful in these situations. Okay, when you're in a can intubate, can oxygenate situation, the move towards surgical or invasive airways, really the cornerstone is cricothyroidotomy. That is what's recommended by the Difficult Airways Society and is what has the highest success rate, least complications overall. Tracheostomy can be done, especially when you have skilled surgeons available. Needle cannula or cricothyrotomy with pressure-regulated device. With unregulated devices, there have been lots of complications in difficult airway management, so this shouldn't be the primary cornerstone. Retrograde wire-guided intubation can be used as well. And then we need to think about backup plans in certain situations, especially when the trachea below the larynx and the mediastinum is involved. So rigid bronchoscopy or ECMO. So going back to our case, we had a 57-year-old male. He was BMI of almost 60, and he needs a nasal intubation for his jaw fracture getting fixed. They previously tried this asleep. It was very difficult. They managed to get an endotracheal tube in, and of course, the cuff was ruptured once they did get it in. So they woke him up, and now he's coming back rescheduled to come to you. So you decide to do an awake bronchoscopic intubation, and him successfully complete it. Okay, so we went over some of the key updates, which really provided a framework for reviewing difficult airway management. We talked about pre-airway management, awake airway management, and airway management after induction of anesthesia, and how to manage the kind of difficult component. We reviewed some of the infographics, which are probably helpful for some people, and how you look at it, and improved over the busier overall algorithm. And we discussed some options for oxygen delivery during difficult airway management, and a brief overview of some invasive techniques.